62. And Mr. Smith has been a runner his whole life, Dr. Thompson. He runs, a distance runner. This joint now, you're diabetic, correct? Okay. So this joint now has kind of let him down. Okay. So in these, one of the things we do when we do these examinations, we look at the flexibility of the toes, whether you can relax your foot. I'm not going to do anything to you. So whether these can move or not, these all right. In this joint here, no motion whatsoever. That's that joint of the big toe. That does not move at all. As a result of his hallux rigida, so see how I'm pushing this? I'm pushing it hard. If you push it much, you could break it. He ended up with a big ulcer underneath here. The most common amputation in all the world is not a BKA. It's the worst one. Is the big toe. Because we cannot solve this issue as to why this cannot move. When he's an active person, he's not an ill man. But he gets, every time he gets going, his foot break down, woof, this thing opens up, and he got months and months of fooling with this ulcer. So today we're going to solve this problem for him permanently. I healed it, but you can't leave it. Guess what will happen? It's going to come back. And people think you ain't know what you're doing. Got to go in there and fix it. So today we're going to do the drawing on him. We can get a picture of this. First thing I want to check is his pulses. He's pretty fit, but I still want to check his pulses. I like to draw on all of my patients. I also like to draw on the foot that I'm doing. I could show you one thing is going on here. We have a change in the circulation. You see this quality of skin? All right? What's going on with this? So as you get distal circulation, this is changing. That's better. So we have a circulatory change. So you're going to check this dorsalis pedis, what's going on here. And if you cannot, I can feel it. We've done this, but this is for the purposes of demonstration today. I want us to make sure we can hear that. I can feel it. And his posterior tibial. Okay, the posterior tibial is easier, and this one is harder. Okay, with the posterior tibial, nice and bounding. So we're gonna let him hear, and I like for the patient to hear it. It's not enough for, us in medicine. We figure, well, okay, well, you understand it. It's the person you're doing it on. I want them to understand it. So our motto of our association is awareness, access, and action. And that's not for us. It's for the people we are attempting to heal. The first thing is they have to be aware. They got to know what's going on. All right? So we're looking for that pulse. Hear that, sir? That's the blood flow in your foot. Hear it? If I don't hear that, I ain't sure I'm doing your surgery. I could, but I have to think about it and then pray on it a little bit. I could do it, but I like to hear that. Music to my ears and to his. So he knows now before we start, and I always do it on the same day. I've done it before for him. The same day when we're going to do this, we do it again. Why? Changes can happen overnight. He could have had a thrombus. He could have had an incident. He could have had a TIA. You don't know. So every time you go to do these procedures, we double check everything again. Okay? So that the patient knows, not for my comfort either, for him and for our documentation purposes, is that 10 minutes before we did this case, a palpable and an audible dorsalis pedis and bounding posterior tibial pulse. Okay? And those are the main vessels coming in here. But I do note that he has some reduction in his circulatory capacity in his leg. That's why it's important to fix this toe. Because in the years to come, we may not have the circulation we have now, but this joint cannot move, okay? And so this will break down on us. It will, in any matter, so it's happened before, it's gonna happen again. And today, we're gonna give this a little bit of a little bit of motion. So this, feel that underneath there, how hard it is. See how close the bone is to the skin. And then this joint now, his IPJ joint, try to see if you can bend that back. Right, it's fusing in place. So now I'm going to do an osteotomy across that joint and slide it up just to take a little bit of pressure off this toe. And that's going to last him maybe 10, 15, 20 years of not breaking down. And it's oftentimes not just enough to keep going. The man runs half marathons. Okay? Now for people like him, I also got to get him an orthotic. You know, you can see he wears real tennis shoes. He's an athlete now. But he is diabetic, and he's had this multiple ulceration, which is driving him nuts, correct? Because when this is ulcerated, he can't run. And that's the only thing he likes to do. So another thing in modern medicine, part of our job, is people want to do stuff. Our job is to see if we can get them back to what they want to do. That has nothing to do with me. The other gentleman we just did, Mr. The great Raleigh, he wants to go to see his daughter in Atlanta, and he got a big hole in his foot. People tell him he can't travel. He's like, Danny, can you fix this? I'm like, yeah, man. It's doing the osteotomy on the fifth, sliding it over, little bunionette, secondary wound closure. Middle of December, he can be flying. That's none of my business. But that's his motivation to get better. Okay, so he's a runner. He can't run because he got a big hole in his foot. He can't shower when the wound is open. He can't bathe when it's open. That's the only thing he likes to do. Okay, so let's do the osteotomy, get him back running, good to go. Nurse is going to come and get you and transfer you in the procedure room. We're going to go over there. You get anesthesia. You get 2 little pinpricks, one here, one there. All of your toe will be numb. It's not a big deal. Make a tiny incision just on the side here and slide a little bit of that bone up enough so that stops ulcerating, and you're out of here. You give it 2-3 weeks and you'll be back to your normal setup, man. No hospital, no blood loss, no general anesthesia, no headaches. Simple, safe, effective. And no loss of toe. Yeah. So these are limb salvage procedures. So for me, once I heal an ulcer, I chasing that patient back down, it's going to ulcerate again, right? Chase him back down and fix the foot. All right, and our website is fixmyfeetbahamas.com. All right, she's coming to get you now. We'll get you in. Come. All righty, Brother Smith, I can lay you back a little bit. Ain't going nowhere. There you go. Like magic. Good. Little swab there for me. Okay. So you look at this picture, Dr. Thompson. The nerves and blood vessels run together. They're concomitantes throughout the entire human body. And when we're working on this stuff, we're blocking the innervation to whatever joint I'm working on. You don't have to go and do a bunch of stuff. These are diabetics, so all this is minimal surf. I'm a minimalist. Don't cause any harm. Just don't touch nothing you need to touch. Right? Like in my house, I don't play anything. All my clothes could go in one suitcase, and I could just put it in my car. That's how much stuff I have. This joint, I'm working inside that joint today. Nothing else. I'm going inside that joint. So only these 2 vessels and nerves I need to control. There are 2 on the top and 2 on the bottom. I'm now about to turn them off so I can work. That's it. No more, no less. All right, Brother Smith, you feel a little cold and then a little pressure. All right, the foot is already pre-swabbed. This is Felicia, the greatest tech in the Bahamas now. You met Dr. Thompson already, I'm sure.
Yeah, sometimes
Yeah. Can I get a gauze? Felicia sometimes thinks I can work magic, so she don't give me a lot of stuff either. Let's go in the middle first, right here. There's a cold spray. Boom, feel the pressure just about now. You feel that, sir? Huh? Did you feel that? A little. A little? What are you feeling? A little. All right, feel that? No, close your eyes. You're cheating. If you're looking at it, then you'll say, yeah. Do you feel that? You feel that? Yes, no, maybe so. All right, you're doing good. Okay, so a little bit of sensation, not as much as you would think. That's that side. Let me do this side here. Good. So these, and this skin is, trying to catch itself because it's been ulcerated, and it's an insult to the soft tissue when you get an ulcer coming. And so you ought to treat the tissue so gently. So hence in the old days when we used to open the foot, it was difficult on the tissue because we had to literally open the foot to get to the joint. Now I don't open the foot. I we can get in and out of these joints in a minimal way. This is minimally invasive surgery right across that. So you can do an H block here. Hey, Reg, well done, man. You can come and watch this one. Very good. And then underneath here, just put a little bit underneath. Good, so you can see where that bone was open before. Okay, this whole thing has been open from what we call stem to stern. See that? From there, all the way down to there. That was his ulcer. That ain't on the plate. We healed it. So this old ulcer started here. That's the tip, that hole there. Came all the way down here. That's the middle of it. Just a piece that went to bone. All the way down there to there. All that was open. To bone. So when that comes back again, my friend, this thing can be nothing to play with. And I want him to call me and say, Johnny, guess what? No. You ain't gonna guess what on me. I do the guessing. These fellas try to catch me off guard too, and see if they could shame me, I guess. I know what they'd be trying to do to me. So now, this is where technology wins the day. So I'm now going to place my needle in the spot where we want to do our osteotomy. Yes.
Almost like a doctor.
Good. So the nerve and blood vessel 1 here, nerve and blood vessel 1 there. The central part of this lesion is here, and I'm going to wanting to go right, boom, right there. Get this up and out and over. So Felicia, you're going to take a picture of this fella right here. And so then give me that thingy again. Give him a picture. Okay, so it's numb now. I'm going to do a picture with this. It's going to come up on the screen. It'll come around this way a little bit. It's going to come on the screen. So this is a C-arm. You all are safe. The scatter rays of this machine is only in between here and there. It doesn't go out into the room. The bigger machines, it goes into the room. You need lead. You need this. We have a lead thing in there. You pregnant, nursing, want to have more children?
Who, me?
Yeah.
Oh, no.
I don't know. I got to ask. I don't know.
I am
Ben, put your foot right there. Good. Perfect. Right there. Sits perfectly still. Press, release it. Say shooting. Good. Can you all see this? Okay. So see where my pin is? I'm in the joint. I'm in. We jamming. So once I got that marker, I'm not fiddling around. So I'm not gonna open the foot anymore. I know where that is. I'm going right in there, where you're gonna feel where that bump is that caused the ulcer. I'm gonna shave that down. The bone piece is gonna come out. Fix his toe where he can. You'll see motion in that toe now, and he's out of here. Put your foot back up. Okay. The pin looks a little funny, but that's life. And then I don't really touch these. You could leave it in and just do. Some people use these as guide wires, but you don't. Another part, you see the ulcer too. So you're really going just distal to the ulcer. Okay? All right, sir. Bam, boom, beanie. We're out of there. Sharps, walking, sharps, out. Boom. Alrighty, you're gonna swab up and come back and we begin. The blood vessel and the nerve and inside. There's nothing else in there but me on the bone. And I come right out and I haven't caused him any problems. He's a runner. So one of the big mistakes we did on him, whoever did this, someone did the big incision on plantarly. You got to do it on the side. Why? When you're running, you could do this on the side of the foot. It's not a problem. On the top, there's no integrity to that skin for you to do a big procedure. You'll be fooling yourself to think you could do that. On the side, though, you got enough juice, enough flesh, enough soft tissue, a little bit of muscle. You could do a lot of stuff on the side, but try not to do it underneath. Okay, so we can go in and out, clean him up when he's gone. You relaxed? Any questions for us? Alrighty. And so all our patients, before they come in, we check their blood sugars, blood pressures, you get their vitals, make sure the score is the score, make sure whatever. Everything got to be right before we start. Just like you're doing a normal theater, just because it's a minimally invasive surgery, still do all of the same work. One form, one procedure. One patient, one goal. So take this fella, goes up here, boom, one there. Take one more. This is Mr. Smith. He's a 62-year-old diabetic. He is a runner, and he has severe hallux rigidus here in his toe. Had a massive ulceration last year. A couple years ago, another problem. So this is an ulcer that maybe was, let's see, 7 centimeters at its pinnacle. Went all the way to bone. We healed it up now, right? It's closed. But I told him I can't take the chance, and he wants to still run. He's still fit. And so we're doing an osteotomy to the base of this MPJ. And where the ulcer was, there's a big piece of bone sticking out. So we shave that, let the bone paste come out, do the osteotomy, slide the bone up, okay? So before we start, I just clear all of this stuff, make sure there's nothing underneath it. Diabetic foot could fool you. It hides things, so before you begin, always double check, make sure there's nothing underneath there. Make sure nothing on the side here, that is. So you have little pockets that can develop. And so I like to move all the dead skin. Make sure I'm going into fresh tissue. And you don't have to draw blood, but you do want to make sure it's clear and clean. So you can see that's the old ulcer. And there's our big point of contact right in here. Okay, so we're going right underneath there. That osteotomy and we can be in good shape. Boom. Part 1. A little spray again, Felici. Special solution. Look it on that. Good. Thompson, I like sprays. I don't like too much dabbing. And that's a good spot right here. So that's the point where we had our needle in. And we're going right back. And that was the origin of the ulcer. So we triangulate these procedures where I'm wanting, this is the place I'm going to, but that's not safe to go in there. So what I'm doing, I'm going this way to get into that, okay? We're going this way to get into that. And get ourselves a little motion in the ocean. Right here. Bam. That's my spot. And we use these tiny blades. Give me 64 again. These are called MIS blades. It's a beaver blade handle. Once again, in the old days, to do that, we'd have to open that toe about that much to flap that down, because I don't want to go underneath, to flap it down. And you can see from that diagram behind you, boy, you got a lot of work to do. Opening is easy. It's like opening a computer. Easy to open it. Closing. and when you close it, guess what? It got to work. And that's where things go a little spooky for most people. So here we're going in the neurovascular bundle. One is on top, one is on the bottom. One is on top, one is on the bottom. So I'm going in between. And this is our origin lesion. We're triangulating his object. Okay? Straight to bone. I'm in the joint now. Literally right in the joint. I'll go underneath here now. And that's the spot. Okay, you're in his joint. You feel anything, Mrs. Smith?
No.
Thank you, Lord. That's always good news. Now, because it's an old, also, we got a lot of scar tissue here. Anything I bump into will be my issue, because I'm the one who healed. I had to do the secondary wound closure. You had to pull all that tissue together. This is fine. Got an elevator, free elevator. Okay, so we're in the joint now. I want to go in. It's a curved instrument, so I go in and this curves around a little bit. Still just in one spot here, going around. And we're there, okay? Now he's a runner, boy, he got good bone. So when you do this kind of work, don't miss breakfast or nothing like that. Okay, can you hear that? That's the bone spur. We're going to knock that off. And then we are going to get this up and over. Get underneath here a little bit. Go under and out. Okay, get my burr ready, Felicia. Good. Magnifico. Boom. Rub it there while we set up my burr. Lady Bam. This is an Osada oscillating bone drill. Goes really fast. This is what allows us to work inside the joint with expert precision. It's pretty fast, it's pretty cool. Japanese made precision tool. Okay, you can touch the handle, you can, just like the stuff we do in arthroscopic surgery and stuff you do for laparotomies, laparoscopies, whatever you want to work on. Okay, make sure the top is nice and sealed. Once that is sealed, we're good. And so first I want to get a little bit of that bone stuff out of there. Little bone stock to go, and then we're going, we're rolling. Bam. You good, sir? Bone. So no one likes to go, back into wounds, but to get these to heal, you have to. All right, you gotta go back in there. We're on bone. Hear that? That's the bone. Boom, under the joint. Okay, I'm right in the middle. See, it's coming right through. So when I'm done, so when I started, I could hardly move this instrument. See now, it can go back and forth inside the joint. Okay? And I'm going to be mimicking the motion I want him to get back in his toe, so this doesn't break down constantly. First incision. For him, there are going to be 3. Second one is to clear everything off the bottom now. Second incision. Boom. In the joint. Now we're going underneath. So where I put the needle on the x-ray, you only got one hole. You ain't nowhere else, so you're inside the joint. Okay, you're not on the nerve, you're not on anything else. You hear that bone, I'm in the joint. I'm coming, I can put my finger now and I can feel the vibration on the side. Okay, I have my thumb right above the burr, and now you're gonna see the osteophyte is gonna be breaking up and the bone paste is now gonna come out. Beauty. See the movement I got now in here? Nice, man. This is the part where I'm wishing one of my nephews goes and says, geez, man, I think I'd like to do this, you know? None of them do it. They all go like, yeah, man, you look like you got a lot of work on your hands, uncle. Congratulations. Okay. So it's a lot of stuff in here. So I'm going to show you all how the bone paste. So I'm in the joint. So remember that hair that was so hard? Okay, it's going to be soft now. And I'm contouring this a little bit. I'm going to come around the back there. Thinking about him running now. I'm not just thinking about this wound not breaking down anymore. I'm thinking about him going for a run one day. So this is a great question for you, Dr. Thompson. So in wound care now, people are doing all sorts of stuff. But we know in healing, there's a new thing that everyone's rushed towards, just pre-COVID. Everyone was talking about it. And we know creates tremendous healing. What is that? And in the world of wound care and healing now, people are talking about mesenchymal stem cells, right? So what is in the middle of bone?
Bone marrow.
Yeah. What are marrow cells?
They are the fluid potent cells you find in bone marrow.
Yeah.
So they're the cells that have the ability to be any kind of cell almost.
And so all this big news they're telling us about stem cells, is that news to us? No. So I'm going to show you all. This is the marrow from that osteophyte. That's bone paste, that's bone marrow. It's not blood, it's bone marrow. Okay? So I'm not going to take all of it out. Why? Because that's also going to help heal. Help heal this process. Now, look at this toe, what couldn't bend. Hello? Jingling, jingling, jing, jingling, jing, 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 jing. You bending, man?
Yeah.
This nigga, yo. Don't go running tonight now. Don't get too excited. All right? But the toe could bend now because I took the osteophyte away. So osteophytes in joints like a pebble in a door. You know, it's a pebble, you know, so the door go to swing and go. It jams because it got the pebble in the door. Now in a diabetic, no one in the world would go inside this man's foot with them old procedure we used to do. You know, be crazy enough to go open this foot. No, sir. But we did it. He's awake, you know. And we got motion in the ocean. Good, no pain. So that's sweet, man. You could hardly see my incision. Okay. So I gotta go call on two things I want to do. I'm just thinking about him running. And I think I can get. No, you're moving your toe. You keep your toes. You don't have to move. Just let me move it. You don't move it. You just let me move it for you. He's still moving it. You're so happy you can move your toe now. Take your time, man. Take your time. Take your time. No rush. No me toques. So I'm So I'm going to do a little osteotomy to the top now. Different blade. Do a tiny wedge osteotomy to the top with a different blade. Just to give me another pack of gauze there, please, Felicia. Alright, so do a tiny osteotomy to the top. So these osteotomies now, when you're thinking about your final cuts for the patient, is like taking a little piece of pie. So picture a pie. So what I'm wanting to do now, his bone is in the right position, but I want it to bend more up. So I'm going to take a little wedge from the top of the bone. So when it heals and the wedge closes, it'll close. That'll bring the toe in a more upright position. Just take a little wedge. So we're going to take a wedge from the top, boom, and we're out of there in the same hole because we're in the same joint. Okay? Same hole, same joint. The juke joint. Thank God I could see the hole. Alrighty. I want to get right in the middle. Probably right here. Good. I'm going right through. Coming right out here. Nice and smooth. So this drill is a great innovation because the old drills used to burn bone. You know, because if you go too fast through bone, it'll burn and then it won't heal properly. So now I'm going to be able to go through, so I'm right through. Good. And now I'm coming up. And I'm coming to the top of the joint now to just take a little wedge out. And we're out of this foot, man. And when this is done and Felicia does the picture, you'll see the actual cut. Okay, so I'm through. And there's also, you know, in hospitalization of these kind of cases, the issue is the infection. So because I'm in a portal and I'm in the joint, I'm doing all this work, your chances of infection, not none, but your chances of infection are very slim. And patients appreciate that. For the diabetic, I think it's essential. Okay, you hear that click? When you hear that click, I am through. You don't have to move your foot, man. Relax your foot, don't move at all. Good. I want to see how much, okay, so now we see how much motion we got in it. Okay? See that? From where it couldn't move at all, and that's the range of motion. So when he does go to run now, at least we got that. See that? That's good. Let me suit you, Felicia, and then you can take your picture, so I don't lose too much. Unless. And he got such good bone stock. You got to be a little firm with that. You got some older people. They could take your toe and snap it. Boy, not on him. You snap your hand off. Any questions, maybe, sir? Anything you want to ask? None? Well, you're in good shape then, no problem. Right with you? Good to go. So I do a little banjo stitch here. One there, and then one across the other way. Let's see. Did you enjoy the music?
Yeah.
Yeah. What you doing for the weekend?
That's the only reaction.
Hey, that's a good answer. You know, some of my parents say, boy, I plan on going to Miami. I'm like, oh boy. And they go. What his name, Mr. O'Brien. So Brian going to watch the Dolphins, man. Say the only reason he get mad, they lost. Say that, so he come back and say, boy, I so mad, this is what happened. This happened to your foot? He say, no, my team lost. That's where he was, Miami. I'm like, oh, jeez. Yeah.
Florida.
Body like Florida, eh? Jeez, man. Yeah, they like they Florida. So that's it. Minimally invasive surgery. Patient moving his toe, tendons preserved, everything is there. Boom, boom. All that through there. Really 3 procedures. So under here, remember where this was rock hard. Can you see me poke? You know, see that now? You got some what we call purchase. So all that bone that was so tough. Look at this now. See how you notice that? I can actually pucker it. I can pucker it all around. And I need that flexible and soft tissue so this will not split open again. And we didn't go through the bottom, we went through the side. So when he's running, whatever he's doing now is fine. And I don't fool with the top because it's too complicated in someone who is compromised. Bam. Okay, clean him up, get him out of here. He makes a special solution too. Get all this stuff off the bottom. No spray. Ding 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 ding. So that's how you operate on diabetics, Thompson. It is so wrong to say we cannot do this for them. You have to do it. It has to be done. It's how you do it. Got to be safe, very efficient. You got to see where you're going. I mean, I wouldn't go inside this foot looking around, right? You'll get into trouble. Look, that'd be like going in a haunted house. You'll get some frights of your life. Back to ground. Oh, you want the picture first? Sorry, Felicia's instructing me and I'm just talking away. Sorry, get the picture first. Boom, boom, boom. Let's go. Pick the pictori. All right. Can you put your foot on this for me? All right. Put your toes like to the top. All right. Right there. Right there. Ding 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 ding. Pressing. All right. I'll be looking at that screen, and here you're gonna be looking at is this fella right in here. Go for it. Bingo. See the cut? You don't see that? Okay? So with that cut now, what have I done to the front of the toe? Shorten it, and I slid it up. See, this was down like that. So see to the top here? See how much up it came? Only a couple of millimeters, you don't need a lot. But that's enough that when he hits the ground, the bone is now in a better position, so the bottom of the toe is not going to split open. Okay? And then underneath there, where all that stuff was, see this now is flat. That's the piece we take out from there. That's flat. So that's where the ulcer was. And that is flat now. So when he hits the ground, we got a flat surface to walk on. His ulcer is caused by that bone being in a bad position. That's it. Go fix the bone. Or leave the man alone. That's it, man. And you get to see it for yourself. You're taking the mystery out of medicine. Yeah? You see it. If you like it, I finish. Now, if you don't like it, I got to go back on your foot.
I like it.
Good man. Done. I'm going to go back and then fix this. See? Hey. Okay? And I like for patients to see it too. You know, people get very, anxiety is based of 2 things, loneliness and fear. That's the source of real human anxiety. And when you do something to a patient and they don't understand what happened, that's a lonely, fearful position. And it creates a lot of anxiety. And sometimes messes up the whole procedure because they got to be psychologically convinced we're going in the right direction. If the patient ain't convinced, I don't think it works. Yeah, right. They got to feel it, you know. That's a Bahamian thing. If they ain't feeling it, boy, you better call on the Lord. Yeah, exactly. You don't know, and then they start imagining all kinds of things. Everything in the world going wrong then. And then, one there. One. Boom. Boom. Soft roll, bleaching. What's the last one you had? Give me the last one you had. That's it there?
No, you want me to
Soft roll. I mean, or you want me to clean now? So you're a technical person in the room, seeing so many of these. Sometimes the doctors be a little lost, so they just have to tell us what to do. Because there is a very precise line of fire and everything that happens here.
3 layers then.
3 layers. So I gotta compress him. So just like I do my dressings in clinic, I put 3 layers on him. Loose in the front end, that's dorsalis pedis. I don't want anything tight around there. Right, controlling, the blood vessel in the middle, coming right down the middle of the foot. You don't want to compress that in a diabetic. You would have caused the problem instead of solved the problem. And posterior tibialis, that vessel is in the back here, so my last thing, we leave that flat. No tape. I don't use no tape on no diabetics. Right? Tape is inflexible. This stuff, this could, right? Here you want to tear this off at night, you can tear this off. If it swell up too much, this will pop. No tape on diabetics. Also, the tape sometimes sticks to their skin. When you pull the dressing off, guess what you pull off? All the skin. Not some, all. And they say, look what Dr. Johnson do to my foot. You're looking good, man. And then I like to, Thompson, remember I don't like to put my stuff straight around, so leave this open. Put a little couple around there, leave the front of that open, so if you have any swelling, doesn't impede our vessels. Correct. So if it does swell, we can be all right. But I think he'll be fine, man. He's such a good gentleman. I think he's going to be super fine. So fine. Oh, cut down the middle there for me, Felicia, sorry. Scissors. One more. Bam. Take that one off, maybe. Bam. This is our patented dressing. Felicia perfected this, not me. It looks beautiful. Really comes out nice. Make you look like you know what you're doing, It helps. Because the opposite is also true. Good. Raise your leg up again. Nice having the patient awake. When I first started, boys have 400-pound legs, and the person asleep. And you don't finish that heart surgery. Now you're trying to put on the dress, and you got to lift them legs and all like a model. And I don't even think they had Voltaren then. Must be something else. So it's nice having people awake. They can assist in this final process. They get to see what has happened. Good. We're out of Dodge. Thank you for letting us do your work, sir. Do you have any questions for us? At all? Anything? So no tape. Once again, I like to close that on the top. So if you get swelling in the night, you call them, they go down. They put swelling, bleeding, boom. Put your finger here, open that, it opens. No tape, no nothing. Nice and clean. Do not go for a run. You're not gonna have any problems. The nurse is gonna give you a sheet, an instruction sheet. You can even see now with his dressing, his side here that big bump was on, that should be flat, even evident from the dressing. Okay, that's supposed to be flat. It's supposed to be, I should be able to put my finger in there. It's an indentation now, where that when you touch it, it was so hard. And I'm out of there. Thank you. Do well, man. We'll see you on Monday. You know, any problems, give us a call. And I hope we'll see you maybe in Marathon, Bahamas in January. Yeah.